Overall, our patients do very well, and it's nice in that we see them for years. Essentially, there's no cure to any of our diseases, but we do have very good treatment these days. So, we develop good relationships with our patients, and again, overall, they do very, very well, and it's very satisfying to see someone with debilitating disease regain function.
Welcome to the Joint Space Podcast, brought to you by the University of Arizona Arthritis Center, one of the first 4 centers of excellence in the University of Arizona College of Medicine, Tucson. The mission of the Arthritis Center is to make a difference in the lives of patients and their families by conducting research ranging from molecules to people, by empowering patients to take charge of their lifestyles, and by educating clinicians and scientists to enable compassionate care and the delivery of novel, effective, and safer therapies. Hello, my name is Tracy Shake, and as Director of Community Outreach and Education in the Arthritis Center, I welcome you to the latest episode of the Joint Space Podcast. In the show, we explore a wide range of health and wellness topics with some of the most respected experts and brilliant minds who share the latest research, clinical care, treatments, and medical innovations to help patients discover new pathways to health and wellness. Today we are joined by Dr. Dylan Harris Lee. Dr. Lee joined the faculty in the University of Arizona Division of Rheumatology and Arthritis Center after completing his rheumatology fellowship at the University of Arizona in 2022. He earned dual bachelor's degrees in biology and economics at Siena College before going on to complete his medical doctorate at Albany Medical College. He performed his internal medicine residency at Pennsylvania State University. Dr. Lee has presented at the American College of Rheumatology annual meeting and has performed quality improvement research on rheumatoid arthritis disease activity. He is a highly regarded mentor of medical students, residents, and fellows. He is board certified in internal medicine and rheumatology. Our conversation today is all about gout. So, without further ado, here is our conversation with Dr. Dylan Harris Lee. So we are pleased to be joined by Dr. Dylan Harris Lee for today's Joint Space episode on gout. So we're going to get right into it and try to educate our listeners and give them background to start out with on what actually gout is.
All right, well, thanks for having me. And overall, gout is a pretty good disease to treat. People do very, very well, and usually on the proper therapy, they can live their life essentially gout attack free. Essentially what gout is at the end of the day, uric acid crystallizes and then deposits into different soft tissue, being joints being most common, but can also go into tendons and muscles and other parts, but most of the time going into joints, and those crystals that form can be very painful and cause a lot of swelling and heat.
So because we know that uric acid is the culprit in gout, what benefit or what role does uric acid play physiologically in the body?
Overall, it's felt that we have uric acid for potentially different reasons, but the two, at least hypotheses that I most agree with and most have seen the most research on is that it helps us stand upright and prevents orthostatic hypotension, which, that would be if we stood up and we would fall over. The other idea of why we have uric acid is that it helps with cognition, that if we look at other animals that don't have uric acid, their cognitive ability isn't as great. So overall, it's felt though those, there's many different hypotheses of why we lost uricase, which is the protein that helps break down uric acid, but those are at least my 2 favorite potential reasons why we developed without that protein. And that's one thing I find very interesting about gout, in that, essentially the question of why does gout occur, and the big overall philosophical answer is evolution. Humans and higher species, primates, are the only animals that have lost the ability to break down hypoxanthine into a byproduct. That essentially humans and apes are the only animals that can develop gout, that we've lost the ability to break down what causes the gout attacks.
Very interesting. So, what are the first signs and symptoms if somebody suspects they have gout, they come into the clinic? What are some of the classic signs and symptoms?
So the classic signs of a gout attack is going to be the first toe, and that happens in approximately 80% of the patients in terms of their first attack. It happens in the toe. Usually it happens in the middle of the night or early in the morning, when for multiple reasons, but it's very painful. It's usually difficult for them to put weight on it, and that's usually the first presenting symptoms.
So, when you are going to diagnose gout, when you have this patient in a clinic, are there any other things that you look for outside of the condition of the big toe, the pain, the middle of the night? Any other classic symptoms?
We look for potential risk factors for having a gout flare or having gout in general. A lot of that is obesity, hypertension, cardiovascular disease, being on certain medications, specifically like diuretic medications, are associated with increased risk of gout. Also, there are some ethnicities that are at increased risk, like Pacific Islanders are at increased risk, and also males.
Okay, so that leads us into, and we know it's more prevalent in men, and as you just mentioned, in certain ethnicities. But how common is gout overall?
Overall, in the United States, about 2 to 3% of the adult population can suffer from gout.
And what makes men more predisposed to gout than women?
Overall, we have an idea that it's probably to do with cortisol levels, as well as some type of hormone regulation. Not fully understood, but most likely somewhere along those lines.
And then as far as risk factors prior to, you mentioned obesity, cardiovascular disease. Are there any genetic factors that go along with that?
There are a bunch of genetic factors, and it all comes down to uric acid and the ability of the body to excrete it properly, either through the kidneys or the GI tract. And there are definitely genetics involved in having increased reabsorption or decreased excretion of uric acid that then builds up the level.
And how is it that gout falls under the umbrella of arthritis, or where is the inflammation piece of that in diagnosis and treatment?
So when you form these crystals, your body recognizes it as something like, oh, this really shouldn't be in the joint space. So then the body starts to attack it, and then it starts to develop inflammation. And if you have 1 or 2 attacks in your lifetime, you'll be fine. You won't really develop any chronic arthritis from it. But if you have chronic untreated gout, that's when it's going to actually cause damage to the actual joint, leading to permanent arthritis.
And we know that talking about people that consume greater quantities of red meat or maybe drink certain types of alcohol, those things can predispose them to gout. Is that true?
Yes. Overall, though, it's felt that they can only go to a certain extent in terms of modification. If someone is, like I kind of mentioned, if they have like 1 attack and we check their uric acid level and it's kind of on the edge of being able to put them at an increased risk, maybe some of those modifications can help. But if somebody is having recurrent attacks, doing a lot of those modifications won't necessarily be a permanent fix, and they still will need medication. And usually if they're on medication and we get them under control, they can, consume those type of products. A lot of those products are, in general, not necessarily part of a healthy diet, red meat, alcohol. So overall, we would, recommend that they limit those just on a healthy basis for anyone, even without gout.
So if someone has one gout attack, does that predispose them to chronic gout attacks? Do they continue typically, or is it one and done?
Having one attack does put you at an increased risk of having subsequent attacks. And as mentioned earlier, it stems from having an elevated uric acid level in your blood that, for multiple reasons that we don't 100% understand, will then all of a sudden form these crystals. Now, there's plenty of people out there with an elevated uric acid who won't develop gout. So it's not necessarily that we check a uric acid level in the general population, but if someone has one attack, well, for whatever reasons, and again, there are some that we know about why somebody's uric acid will then crystallize, but then they're more likely to have more attacks in the future.
And so once you've diagnosed gout in a patient, how do you manage and treat it?
So there's really a split in terms of the management and the thinking of gout. The first is the acute flare and treating that. As mentioned, it's extremely painful. Often patients can't necessarily bear weight on whatever joint. And I'll say this as well, that most of the time it's one joint involved. About 80% of the time it's just going to be one joint. The other 20 could have more than one joint. And for those acute attacks, there's multiple things we can do. There's certain oral medications, for example, one's called colchicine that we can try. If it's really just like one joint, like a knee, sometimes we can inject it if they see us soon enough. And there are other medications for acute attacks. Then the thought is, do they need therapy to help lower their uric acid level permanently? And that comes into a decision tree of, are they having more than one attack a year? Do they have lots of risk factors for more attacks? Are their kidneys involved? Do they already have the joint damage from their gout? Like, have they, essentially that would happen if they have multiple attacks and don't really notice that it's actually gout that's going on. But then we get x-rays and there's definitely changes from the gout. So putting someone on therapy lifelong becomes kind of the second decision after treating the acute flare.
So you referenced this in your prior answer, but what are the complications? Maybe we can add to that. What are the likely complications if gout is left untreated?
So specifically in the joints, having untreated gout can eventually start to cause erosions of the joint itself, and that will lead to permanent damage and dysfunction of that joint. You can also develop what's called tophi, which is essentially a collection of those crystals in bump or a ball that's in the joint itself, and that could be extremely painful. Even if there's no bone destruction, having essentially a marble in a joint will be very, very painful. Then there's a few complications that can help or happen outside the joints, and those are primarily in the kidney. You can have stones that form in the kidney, just like when people say, oh, I have kidney stones, there's multiple types of kidney stones, and one of them could be gout. And then also sometimes gout can deposit within the kidneys, and that's a serious problem.
And how is that treated if that occurs, if it presents in the kidney?
So that would have to be treated with rheumatology and a nephrologist. They would usually have to go on some type of medication that's going to lower their uric acid, and we would treat them very similar to the chronic gout patients.
We often hear about pseudogout. So what are the differences between gout and pseudogout, and what is pseudogout?
So pseudogout, I don't really like the name pseudogout because people try to think that it's like very or closely related to gout. The crystal that happens in pseudogout is very different than the one seen in gout. Gout is something called monosodium urate, and it comes from uric acid, while in pseudogout is calcium pyrophosphate. So the type of crystal is different. Now, pseudogout, we have less understanding of exactly what's going on and why it occurs. There's some conditions that can predispose someone to have pseudogout, but most of the time it's just purely idiopathic, or it just happens in that particular individual. But the crystal is overall a different type of crystal seen.
And what is the treatment for pseudogout? Is it the same or different?
So pseudogout, kind of along the lines of, we don't quite understand the mechanism or why it occurs, is we don't have great treatment for pseudogout. We'll try several different therapies, and some find benefit, some don't. And we look for some of those causes that we know about. Some of the popular causes of pseudogout are having low magnesium, having a low functioning parathyroid, having a condition called hemochromatosis, and another condition called hypophosphatasia. So if someone has one of those four conditions, we can treat those underlying conditions to treat the pseudogout. Other than that, we do try treating it similarly to gout, but it's not as effective as the treatments that we have for gout.
So when you have a patient with gout or pseudogout, they've come into the clinic, you've diagnosed them. What is the length of the course of treatment and basically to recovery typically?
So for a gout, if someone's having an acute attack, if they were to do like nothing at all, like just stay at home, their attack would usually resolve within 5 days to a week. Now, with medications, we can often blunt it, so hopefully they're only having the flare for 12 hours or so. And if we know a patient can have gout flares, we often have given them medications that they could take at home. If they're into that category of needing therapy to lower their uric acid, once we get that uric acid under the goal, they should not have another gout flare unless they stopped their medication or forgot to take it. So that's why it's a really satisfying disease to treat, because once we get their uric acid level at goal, they should not have another attack.
And this is, I'm sure, a very basic question, but is testing a uric acid level a blood test? How is that evaluated?
It is a blood test. There's kind of a game of telephone that went wrong somewhere, that during a gout attack, your uric acid will actually falsely be low, or it will falsely decrease. Sometimes we still get it and it can still be very, very elevated, particularly people who are very high levels of uric acid. But somewhere along the game of telephone, someone said, don't check your uric acid level during a gout flare. But we absolutely do check uric acids during gout flares. And if it's still elevated, that's suggestive of that it's truly a gout that's what's occurring, but it is a blood test.
And so obviously we know that there is a shortage of rheumatologists, certainly in the Southwest, but throughout the entire United States. So say somebody has or suspects they have gout. Is this something a primary care doctor can take care of? Do they go to an urgent care? Do they go to an ER? What would be their first course of action?
Overall, yes, a primary care can diagnose and treat gout. It really depends on how severe the first attack is. If it's so severe that the person can't ambulate around their house, then they're probably going to an urgent care, if not an emergency department. But let's say they got through the flare and they have an appointment with their primary care the next week. They can discuss it with their primary care. They could check their uric acid. They could potentially get some type of imaging, either just an X-ray, an ultrasound, to see if there's any chronic damage. And most primary cares could start therapy if they need to for the lowering of the uric acid.
So if somebody is concerned that they may be at risk for gout for any of multiple reasons, what are some preventive measures that people can take from the get-go?
That's a good question. That's very hard to study. If someone is very, very concerned, then some of those lifestyle modifications we're discussing earlier would probably be the best way to potentially help stop developing gout, in terms of, eating less red meat, less shellfish, drinking less beer or spirits. Overall, weight has a lot to do with gout. Being obese puts you at a higher risk, so making sure that you're, losing as much body fat as you can in a safe manner. Those are ways that can help prevent, especially if you have a strong family history of gout. Those are things that can be done to help potentially prevent developing gout.
Okay, and as far as in your experience, what types of research advances have you seen in the past, and do you know of that are being made currently?
So overall, we do have really good treatment for gout. Most patients were able to get underneath control that we see. Patients with very, very bad gout that have a lot of those tophi that I was mentioning earlier, we often have to put them on medication that helps dissolve them very quickly. And that medication is essentially the enzyme that humans and apes have lost. With that being said, the body can develop anaphylactic antibodies against that medication. So further development into developing some type of medication that has less of that response that can help lower people's uric acid with severe gout is probably in the future. There's also been some investigation into possibly medications that help decrease the uric acid levels via the gut. A lot of the targets currently have been in the kidneys or the actual breakdown products right before the uric acid, but they're looking into possibly medications that will help prevent uric acid reabsorption in the gut itself.
So, if I were a patient with gout, one of the first questions I would ask is, does this put me at risk for future kidney disease? Does this put me at risk for any other rheumatologic type diseases in the future now that I've experienced this?
As long as you're treated and you stay on the treatment, there really shouldn't be any complications. Only if you were to stop your medication and stop seeing physicians, that's when you could potentially experience some complications from gout.
So, is treatment, so when you have an acute flare, is it a short-term treatment, or are there some people that are on a lifetime of medication for gout?
So for the acute flare, you're usually only on it for a few days, and sometimes it's even just a steroid shot. If it's just gout in the knee, and you see someone quick enough, essentially all you would need is a steroid injection directly into the joint. The decision then becomes of how frequently are you having flares, and do you need to go on some type of treatment to help prevent future flares.
So I know that we've had some discussion in the past of those who experience gout also having multiple rheumatologic diseases at the same time. Is that something that's more common if someone has gout, that you also see them with other joint disease, or is that just by happenstance?
There is a slight increase of gout in rheumatologic patients for various different reasons. First is having some type of underlying joint issue makes that joint more likely to have the crystals form. The second thing is a lot of our diseases, specifically plaque psoriasis, there's such a turnover in the cells that the cells are breaking down and causing an increase in uric acid. So kind of twofold reason there for why some rheumatologic patients do develop gout, because of the joint damage happening from their other rheumatologic disease, and then the breakdown of tissue causing an increased uric acid level.
Okay, and so when you mentioned if a gout attack is left untreated and the uric acid buildup causes joint damage, does it damage the cartilage? Does it damage bone? What happens in that process?
So it does damage the cartilage, and then it starts to erode into the actual joint, the bone space as well.
In the diseases that you treat as a rheumatologist, how often do you see gout patients?
So in terms of patients that I see that only have gout, I tend to only see the patients with severe gout, if that's the only disease that's going on. And that's usually patients with very large tophi. And a lot of them I actually suspect might have some type of underlying genetic condition that's leading them there. Actually, a few of those patients of mine are actually female, which is kind of interesting to think about because this is a male disease or a male dominant disease. So I definitely think those patients have. Now, in terms of testing for genetics, does it change what we do? Not necessarily, but often those patients need more intense therapy. I, have other patients who also have psoriatic arthritis or plaque psoriasis and rheumatoid arthritis, and then also have a little side portion of gout. But in terms of having just patients with gout, I only have a few, but they tend to be the severe cases.
And can you describe to us what tophi actually is?
Tophi is a collection of those crystals, and that has kind of formed a mesh into a solid product that often they're found in the joints, but sometimes they are found in other places. One of the most common places sometimes we find them is actually in the pinna of the ear. So they can really deposit anywhere. There's plenty of case reports of them ending up in other places that are very unusual, but usually they stay in the joints.
Very interesting. And so Obviously this is one of the conditions you treat as a rheumatologist, along with numerous others. So on a personal level, coming from being an internist, what developed your interest in going into rheumatology and treating diseases like this?
In general, what got me interested in rheumatology is that there's still a lot of unanswered questions, that there's still a lot of unknown. Gout we know pretty well. Pseudogout's another, issue as mentioned before. There's still a lot of unknown there, but overall, a lot of our diseases, we still don't know why they happen, and we're still looking for better treatments for them. So I liked that we're still exploring and still having to think about every disease on a daily basis.
Where do you gain the greatest satisfaction from being a physician and in particular a rheumatologist?
Overall, our patients do very well, and it's nice in that we see them for years. Essentially, there's no cure to any of our diseases, but we do have very good treatment these days, particularly for rheumatoid arthritis, psoriatic arthritis. You can't go, watching TV for more than 30 minutes without seeing several commercials. So, we develop good relationships with our patients, and again, overall, they do very, very well, and it's very satisfying to see someone with debilitating disease regain function.
So today, once again, thank you to Dr. Lee for joining us in the Joint Space podcast to teach us all about gout.
Thank you.
Joint Space, where people, ideas, science, action, and curiosity come together. The Joint Space podcast is brought to you by the University of Arizona Arthritis Center. To learn more about the Arthritis Center, please visit arthritis.arizona.edu. We appreciate your interest in this show and our Living Healthy with Arthritis programs. If you enjoyed this episode, please give us a like and subscribe to our podcast on your favorite platform. Joint Space is produced by Greg Gillis with assistance from Luke Brower. Graphics were created by Luke Padway. Our theme music is courtesy of MC Yogi and John Pattern. Thank you for listening. Every step counts toward better joint health.